Hello and welcome to Local Doctors on Call. I'm Alix Redmonde. Itchy skin is pretty common and you may have a rash or two in your lifetime. But do you know if you have a chronic skin condition? Can you tell the difference between the two common skin diseases often confused with each other, psoriasis and eczema? And where should you seek help? You know, both of those conditions have similarities, but one is more serious than the other, and they do require different treatment. Well, Dr. Heidi Anderson of Dermatology and Oculoplastic Consultants is back to answer your questions and explain the difference between psoriasis and eczema. She is trained in dermatology and pediatrics at the University of Cincinnati School of Medicine and specializes in family dermatology and therapeutic laser treatments. Welcome back, Dr. Anderson.
Thank you very much for having me.
So what is the number one sign that we should look for to tell us, like a little red flag, if we may have either eczema or psoriasis?
So eczema and psoriasis, what they share in common is inflammation, which translates into redness, and scale. So inflammation, scale, and then sometimes itch. They do have typically very distinct patterns, and so that's what's kind of the beauty of dermatology, is a lot of it is detective work and looking at the patterning of diseases.
Now when you say looking at the patterning, is this something that you would do under a microscope, or could you see like a blotchy spread that has a certain pattern when you look at the face?
So you stand back and look at the patient. Psoriasis usually has typical locations on the body. Majority of times psoriasis is elbows, knees, and the back of the scalp. There's other locations, and there's also subcategories. Eczema, when we look at patterning, so it's again visual. Some eczema is an allergic reaction. So you look at a pattern from a plant, you look at pattern for nickel. But eczema, that a lot of people think about, that's kind of a skin allergy. That usually starts in the folds, so the folds of the wrists, the folds of the elbows. So it really is trying to differentiate the quality of scale up close, and then macroscopically away from the patient, the pattern where it is on their body.
All right, let's go ahead and give the phone number out right now, because I'm sure eczema is a pretty common condition, yes?
Yes.
All right, 361-4675. We've opened up the phone lines, and we are live tonight. We'd love to hear from you, whether you think you may have eczema or psoriasis. Those two skin conditions are both pretty common, eczema being more common. And 361-4675, go ahead, pick up the phone. With eczema, what are the common causes? Can it be brought on by stress, or is it just something that happens genetically?
So there's a combination. So the classic eczema, when we talk about a skin allergy, maybe a patient that starts when they're young, and they also have allergies or sensitization, lungs, intestines, so food allergies, environmental allergies, asthma. That usually is more of a genetic predisposition. Absolutely, there's environmental factors. So we always talk about things that touch their skin, smoking, or foods that they ingest or inhale. And then stress is a hormone, cortisol. So I'll say to a lot of people, stress may not be the primary cause, but it can aggravate rashes tremendously.
All right, if you'd like to call in with a question about either eczema or psoriasis for Dr. Heidi Anderson of Dermatology and Oculoplastic Consultants, pick up the phone right now and call 361-4675. That's 361-4675. Now, are there different types of eczema? Are there, like dry eczema or?
So the broad category is dermatitis. Anything with an itis means inflammation of the skin. For eczema, the atopy that I talked about was that culmination of many different allergies. Then when we break down eczema, you betcha, people can have an allergic contact. That would be your plants and your nickel. And that usually is acute and blisters and is very, very uncomfortable. They can have a drier type of eczema called seborrhea, a little bit of scaliness across the elbows, or part of the eyebrows or around the nose. Sometimes people have chronic cumulative hand eczema, and those are people, we say mechanics, nurses, people that are consistently day after day breaking down the skin barrier. So many different things can lead to inflammation in that big wasteland of eczema.
So that could be probably brought on by a chemical too, if you're working with chemicals?
Absolutely. So your acute contact is usually blistering, your irritant is usually dry.
Now what about babies? Sometimes we see babies with those little scaly patches on their face.
So babies can have more seborrhea, so seborrheic dermatitis, so that inflammation of the skin. Babies can absolutely have eczema. They have it a little bit of a different pattern. So they usually have it on their cheeks, around their top of the feet or the ankles and on the top of the hands. Then they usually grow around 6 months to a year. Then they switch to that category if it's more of a genetic eczema, to where they have it on the wrists, the elbows, around the ears or the back of the knees.
Is it more common for boys or girls or men or women? Or?
Not necessarily a genetic tendency, but definitely more of a familial, something that runs in the families.
All right, now if you're diagnosed with eczema, is there a certain way that you should try to treat yourself, or should you go and seek help from a dermatologist and get some kind of a treatment?
A lot of times, to get extreme treatment, depending upon the severity, you do have to be put on probably topical steroids, and a lot of good education comes in place. The reason for the education is if we can be almost like a detective and look back, what have they become in contact with, how can we change, how can we repair their skin barrier, because eczema breaks down the skin barrier and makes them more susceptible for infection. So the biggest thing is inflammation and quality of life, and then they come in and see a dermatologist like myself.
And what are some common treatments that you were prescribed for somebody that's diagnosed with eczema?
Topical steroids. Topical steroids are pretty much your number one thing because they suppress the immune system in the skin. Topical steroids come in many different, we say vehicles or formulations, so you can figure out if you're treating the scalp, if you're treating the face, or if you're treating the extremities. Then I talk seriously about barrier repair, because eczema becomes so red, scaly, inflamed, and then people itch it. We kind of joke around that is it the itch that scratches or the scratches that itch? And so you really got to calm down the moisture barrier and put back lipids and ceramides that are in many over-the-counter moisturizers.
Now, can it spread from one area to the other? If you touch it, then you touch an uninfected area?
If it's the immune system, no. But if you secondarily get it infected with staph, which happens quite a lot, you can spread the staph, and that also worsens eczema because it's related all to the immune system.
Now, what about being transmitted to another person? Can you have eczema and then you touch someone else and they get it?
No.
Can you catch it from animals?
Nope, it's not really considered an infectious disease, so you can't catch it. Animals can maybe trigger your immune system, but they can't give you eczema by them having eczema and transferring it directly to you.
Now, you talked a little bit about some of the topical steroids that you would put on. So I guess that would be an ointment or a cream.
Ointment, cream, foam, solution, sprays, depending on if you're doing the scalp. We've really come a long way. I mean, even pharmaceutical companies have done a lot of research to understand that a cream and ointment can't get to your scalp. It gets stuck in your hair. So they have sprays, they have foams, they have solutions. People will have itchy eczema in the ears, and so they actually have oils with steroids that you can put in the ears. So we really have fine-tuned. The other thing with steroids is they come in a variety of strengths. There's about 7 different strengths and then 4 different categories. So you can customize based on age and skin type and strength the topical steroids.
All right, if you'd like to call in with a question about either eczema or psoriasis and speak directly to Dr. Heidi Anderson of Dermatology and Oculoplastic Consultants, phone line's open right now. We'd love to hear from you. The number is 361-4675. That's 361-4675. Call in with your questions. Don't be shy. Pick up the phone. How good are these therapies that you have? Would you say that they're pretty effective?
Honestly, they're pretty effective. What you have to figure out, though, sometimes we patch test. Patch test means that when we usually use either 29 ingredients or 36 or even 64 ingredients, and it explores chemicals that may trigger your eczema. We've really discovered down even into the pediatric population that cleansers, soaps, detergents, hair dyes, things that release formaldehyde in clothing and detergents can just make someone's eczema awful. So we can customize and show them what to avoid by patch testing them.
All right, when we come back from the break, we're going to talk a little bit about psoriasis and eczema. And of course, psoriasis is a little more serious, so you do need to know what the difference is so that you can be safe and take care of the problem. We have Dr. Heidi Anderson of Dermatology and Oculoplastic Consultants with us this evening answering your questions. So go ahead, dial in right now, 361-4675, 361-4675. We'll take your phone calls right after the break. Please stay with us. It's okay now. Back to Local Doctors on Call. Dr. Heidi Anderson of Dermatology and Oculoplastic Consultants is here tonight answering questions and explaining the difference between psoriasis and eczema. And we talked a little bit about eczema. It's fairly common, but psoriasis is actually a little bit more serious. So we're going to talk about that. Go ahead and call us at 361-4675. That's 361-4675. Go ahead, pick up the phone. Alrighty, so psoriasis. What are the major differences between psoriasis and eczema, and how can somebody out there tell if they should really get in quickly to see you?
A lot of people do outgrow eczema. And eczema is almost a hypersensitive immune system, an allergy. Psoriasis is not. Psoriasis, we say, is an unregulated or an overactive immune system. Skin cells are rising quickly to the skin, the top layer, so you get extra scale, you get inflammation. So they look different. Psoriasis unfortunately has a chronicity to it. Psoriasis also has about 12 to 15% where people have psoriatic arthritis, and they actually have a whole internal inflammation of their joints. People who have psoriasis are at a much higher risk for chronic cardiovascular disease. People who have psoriasis are a little bit of a higher risk for depression as well.
So which is easier to tell, if you have the arthritic kind of psoriasis or the exterior? Like, do you see the exterior and that kind of gives you a red flag?
The exterior is so much more easier to both diagnose. Also, a lot of patients don't think that a skin disease could also affect joints. So the knowledge of psoriatic arthritis is that we need to create more awareness of it.
Can it go from the skin to the joints if left untreated?
So it's not that you get a psoriatic patch on a knuckle and then it spreads down. There really is a patterning of psoriatic arthritis. Most people present with skin first. Only a small percentage ever have joint disease before they start to have scaliness on their skin.
Can having these skin conditions, and especially psoriasis, affect the quality of someone's life?
Both can affect the quality of life. When we talk about psoriasis, unfortunately, it's often in exposed areas. So it's often, we talk about knuckles, scalp, having, scaliness on their shoulders, their hands. Psoriasis could, both of them, because you've broken the skin barrier, you can have a lot of infection risk, so you're exposed, so there's cost, there's infection, there's some embarrassment or self-consciousness to it. Psoriasis, we spoke a little bit about the joint disease. So I speak a lot with my patients about the quality of life, about compliance, and how we can make their psoriasis less of a disruption.
When you talk about compliance, do you mean, you have to take your medications and you have to, change your diet a little bit and well, what about going out in the sun?
Great frustrating point. So there's a fine line for psoriasis. Psoriasis, when we say it's an unregulated immune system, I use light therapy or phototherapy. So I have in a laser something that's UVB, so ultraviolet B wavelength, and I use it to treat psoriasis. Some of my patients that have extensive psoriasis or go off on vacation, I do give them permission for about 10 to 15 minutes a day to expose their affected areas to the sun. So the reason I don't like light is because it suppresses your immune system, can lead to cancer. But that same side effect of suppressing or calming the immune system is why it helps psoriasis.
Now, is there a certain part of the body that psoriasis might hit first? So you would notice it first, say, in your hands or in your elbow creases?
For psoriasis, we think it's more friction. So we think there is some trauma related to it. So that's why elbows, the back of the elbows, the knees, the back of the scalp, and even nails. People can have psoriatic changes of their nails. So that's the patterning of it a little bit. For eczema, it's the opposite. We don't know why eczema has the pattern it has.
All right, if you'd like to call in with a question for Dr. Heidi Anderson of Dermatology and Oculoplastic Consultants, you may call 361-4675. That's 361-4675. And we have Miss Biggs on the phone. Hi, Miss Biggs. Welcome to Local Doctors. What would you like to ask Dr. Heidi Anderson?
Hello?
Yes, you are on the air.
I would like to know, how do you diagnose it? How can you tell it from a different rash?
So psoriasis versus a different rash. The most important thing is really getting a good history, trying to figure out if there were any triggers, patterning, any new medications, how long somebody's had it, how it's progressed. So history is very important. Then clinically, the examination is important. Is there a pattern where it typically goes where psoriasis goes? Is it a pattern where it looks like it may be from a chemical that touched your skin? And then sometimes response to treatment. There are times where I absolutely biopsy something if it doesn't respond to treatment, or it's progressing, or it's not clear cut.
All right, Ms. Biggs, thank you for your phone call. And if you'd like to call in with a question for Dr. Anderson, the number is 361-4675. That's 361-4675. We are talking about eczema and psoriasis, and we're answering your questions. How do you diagnose the psoriasis? How do you have to take a piece, little skin sample and look under the microscope, or?
Not often. A lot of times it is a little bit stereotypical the way psoriasis presents. There are some confusing aspects. So there are subcategories of psoriasis. There's one that's absolutely smooth, and it's called inverse psoriasis. And so it takes place in armpits and the groin. And the reason it's so smooth is that the dry scale is not able to form in a warm place. There's also, we say, pustular psoriasis, so tons of white bumps that happen on people's palms and soles. There's many different things that can cause that. So those may be the unusual instances where we biopsy.
All right, we have Anthony on the line. Hi, Anthony. Thank you for calling Local Doctors on Call. Go ahead, you're on the air.
Hi, doctor. You mentioned something about seborrhea. I have some redness between my eyebrows, and mostly in the parentheses in the side of my nose, and it's red. Now it comes and it goes. I thought it was at first razor rash because I shave with but it isn't, because I don't shave up on the side of my nose. It's very annoying. It like I said, it's erratic. I've been treating it with over-the-counter cortisone plus 10. And also, I had a prescription for hydrocortisone. But what worked, what I want to know is what's better, the hydrocortisone prescription. There was another tube of ointment or cream I was using. It was called, desohexametazone or
Desoxymetazone.
That's it, yeah. That seems to work the best. That is really, it's very expensive.
Yes.
But it really worked and cleared it up in a couple days.
So what you're defining or describing is seborrheic dermatitis, so inflammation of the skin. Also has a little bit of an oil gland pattern. So across the eyebrows, around the nose, sometimes down the skin folds, and sometimes around the ears. We say facial dandruff. Can also present as scalp dandruff. Your question is very legitimate in that you're describing different strengths of steroids. So desoxymetazone is a very strong steroid. Prescription strength hydrocortisone is stronger than over-the-counter Cordaid. To be honest with you though, none of us really like to use chronic steroids on the face. You can get kind of a steroid addiction syndrome. The skin craves it when you try to remove it. You can get steroid acne. You can also absorb it and thin the skin. So in an emergency situation, I will have people maybe calm their skin down for a few days with a topical steroid, but we have wonderful alternatives that are non-steroidal to use so that you don't run into the complications of chronic steroids. So it really determines how frequently you're needing it. There are very good over-the-counter non-irritating cleansers and moisturizers to also add into it so that you can shy away from using such strong steroids like desoxymetazone for benefit.
All right, Anthony, thank you for your phone call. And we do have Savannah holding on the line. Thanks for holding. What would you like to ask Dr. Heidi Anderson?
I understand that you mentioned seborrhea as maybe a condition listed under eczema. My eyebrows flake, and I have a crusty accumulation like a hyperactivity of cells around my hairline. And it's not all the time. It's just every so often. Can you tell me anything about this?
Absolutely. You are describing seborrheic dermatitis. Sometimes there's an overlap, and we will actually guard ourselves and say sebo-psoriasis. So there's an overlap between skin psoriasis and seborrheic. Dermatitis, you mentioned, absolutely, inflammation of the skin. So red scaliness around the hairline and between the eyebrows and the nose. Stress can aggravate it. Medications can aggravate it. Sometimes certain, we say neurological conditions, and that might be the stress relation, can aggravate it. But you're absolutely describing seborrheic dermatitis. For the scalp, I usually work people over the counter, and then if they have no success with some of the over-the-counter shampoos, we move up the armamentarium that we have available as far as prescriptions. For the face, depending on how severe and how frustrating it is and how often you outbreak it, we talk about the maintenance cleanser and moisturizer that I mentioned a little bit earlier. We also have non-steroidal things that can calm that redness and inflammation, which leads to overproduction of scale. So there's a lot of great options, but it can be very frustrating.
Thanks for calling in, Savannah. And if you'd like to call in with a question for Dr. Heidi Anderson of Dermatology and Oculoplastic Consultants, phone lines are open. Right now's your opportunity, and the number is 361-4675, 361-4675. We'd love to hear from you. Let's talk a little bit about scarring. Is it possible that because psoriasis is a little more serious?
Scarring, there's two aspects. A lot of people think discoloration of your skin is scarring. So I really tease that out and say that, you might have that red inflammatory plaque or spot just because of the inflammation, but it really hasn't scarred you, meaning that it really hasn't changed the collagen underneath the skin. Sometimes psoriasis can be so thick on the scalp, it'll break the hair, but it doesn't scar. You can regrow hair. So it really is a discoloration, sometimes a trauma to the hair, but not a tremendous collagen effect like a true scar.
All right, if you would like to call in with your questions for Dr. Heidi Anderson, the number is 361-4675, 361-4675. We're going to go ahead and take a little break, and when we come back, we will take your phone calls, so please stay with us. We'll be right back. Welcome back to Local Doctors on Call. I'm Alix Redmonde, and Dr. Heidi Anderson of Dermatology and Oculoplastic Consultants is telling us all about psoriasis and eczema. Those are two skin conditions that are very often confused with each other, of course psoriasis being the more serious of the two. And I think also for people that want to learn a little bit more about skin, you guys are doing some lectures and workshops that are going to be open for people to come in?
Absolutely.
Right? Tell us about that.
Yeah. Wednesday, August 8th, myself, Dr. Anderson, I'll be giving a lecture over at Glen Ridge. Glen Ridge and Palmer Ranch is going to have a roundtable discussion with about 12 physicians of the community. We each get to submit 3 topics of conversation. I'll probably do mostly skin cancer, but we have orthopedics to geriatrics, so that's going to be exciting. Back home, so back at our office the same day, Wednesday, August 6th, Dr. Brannon will be talking about droopy eyelids from noon to 1. And he's got a great audience thus far, and we'd always invite more people to come.
All right, and if you'd like to get a hold of Dr. Heidi Anderson and get more information on that, you can go online to skinidocs.com. That's one word, skinidocs.com, or simply pick up the phone, easy number, 925-DOCS. That's 925-DOCS. All right, and now we have Mary on the line. Hi, Mary, thanks for holding on. What would you like to ask?
Hi, I'd like to know if it's possible to get psoriasis on the genital area.
Absolutely. So pediatric psoriasis, sometimes when kids in the diaper area, they should not have eczema because it's a warm, moist location. So typically, if you have a red, scaly rash that persists, it can be psoriasis. So it's not so often overlooked because we don't think about that in the pediatric population. In the adult population, yes. So there's that other category of psoriasis called inverse psoriasis. And inverse psoriasis means instead of elbows and knees and scalp, it's actually armpits and genitals and groin. And it's usually a pink, smooth plaque, very, very itchy, and sometimes can get secondarily infected, but you're absolutely correct. There is another form of inverse psoriasis.
All right, thank you for your question. I mean, that's an interesting question. Can that ever get, can that ever be seen as possibly a herpes thing? Would you need to do tests to make sure that it was one or the other?
Not so much confused with any other infectious diseases because it really is kind of a long plaque, but what happens is you make sure that yeast or bacteria or fungus haven't jumped into the area and made it worse.
All right, now we talked about eczema, but we didn't talk about psoriasis and whether that was contagious or not.
Psoriasis is not contagious. There's a genetic tendency, so it runs more commonly in families. There's some psoriasis that can be brought on by medications, so some blood hypertensive medications, but it is not contagious.
All right, we just have a little bit of time left, and we have time for one more phone call. If you call in quickly, 361-4675. That's 361-4675. So what's new and exciting with research for this?
We've done a lot of research when it comes to psoriasis, primarily because we understand that it's the immune system of the skin. So people who have very severe extensive psoriasis and joint disease, we have a whole category called biologics. You see it a lot on TV when we deal with arthritis, Enbrel, Humira, and these are all looking at the immune system, looking at something called a T cell lymphocyte in your skin, and seeing that it's aberrant, that it's wrong, that it's firing, that it's stimulating other cells, and we try to shut it down with biologics that are either injected at home or even given every 6 weeks, sometimes through a port or a vein.
People don't realize very often that their skin is an organ. It's the
It's
largest
often
organ you have.
It's often forgotten and abused. You're right.
All
Yeah.
right. Well, that was a ton of information.
Yes.
And if you'd like to reach out to Dr. Anderson, 925-DOCS. We'll see you next time on Local Doctors on Call. Check us out on Facebook. Make sure you press that like button. And remember, it's your health. We'll see you next time.